Friends, my topic today is micronutrients in critical illness, and a topic that's quite often neglected. The learning objectives of my presentation are to understand that micronutrients are very important for all biological processes involving macronutrients, and if you don't correct deficiencies, you may have adverse effects and even death. The term micronutrients, of course, means both vitamins and trace elements. The benefits of micronutrients far extend beyond the claimed benefits to immunity, and mega doses of micronutrients are not needed. Micronutrients can be detected by clinical signs and symptoms, or at least suspected. And even when a patient is seemingly getting adequate enteral and parenteral nutrition, micronutrient deficiencies can occur. I want you to be convinced that they are not academic curiosities, but actually occurs not infrequently in critically ill patients. So let's take the example of a 30-year-old patient with excessive alcohol intake with severe abdominal pain and elevated lactic acid levels, and all the imaging studies are normal. There is no evidence of peritonitis, and enteral nutrition makes the abdominal pain worse, and we don't know exactly what's causing the abdominal pain. What is the reason for all this, including the metabolic acidosis that the patient has? Is it ischemia, thiamine deficiency, hepatic, or toxicity? Keep the thought in your mind. And another quick patient, a fistula patient, high output fistula, and the patient develops glucose intolerance, loss of hair, and a peculiar rash, images of which I'll show you later. Is it thiamine, zinc, selenium, or biotin deficiency? Generally, more emphasis are placed on macronutrients, how much carbs, how much proteins, how much lipids, and the role of micronutrients is neglected. Not understanding that you need micronutrients for the optimal metabolism of macronutrients. In fact, when a patient is on TPN without giving micronutrients, zinc deficiency can occur within 2 weeks and selenium within 4 weeks. We'll talk more about it. Of course, with enteral and oral nutrition, the deficiency is variable because of the content of micronutrients in enteral feedings. Here are some of the examples of papers that I will use during my presentation, and I'll be happy to send you copies of the original papers if so requested. Micronutrients are not adequately provided if enteral and parenteral nutrition goals are not met. So it means that we have to make sure that the goals are met, and the goals include the content of micronutrients in parenteral nutrition, and the goals include the content of micronutrients in enteral feeding. If 1500 cc's of a standard formula is used, you can be reasonably sure that the daily requirements are met. Here is an update on the use of micronutrients in parenteral nutrition, an international consensus paper, and I was happy to be part of it. The conclusion of this paper was that we need to sensitize clinicians about the use of micronutrients as an integral component of nutrition therapy. But even though the routine administration of micronutrients, including trace elements, is recommended, it is not always followed. How often have you known parenteral nutrition being given to your patients without adding multiple trace elements, or without adding the right composition of the multivitamin preparation? So the consensus opinion has made strong recommendations regarding accountability. We have to be accountable for good medical practice. Micronutrients are generally absorbed in the proximal duodenum and the jejunum, as you can see in this slide. And of course, you know the role of the ileum, terminal ileum, in absorbing B12. But usually it is the proximal bowel, the duodenum. And that is the reason why when the duodenum is bypassed, either by surgery, intentionally or otherwise, you will find that micronutrient deficiencies do occur, and the same information presented in the previous slide is shown schematically in this slide. One thing that we have to mention at this point is that kitchen prepared diets, very popularly used in our country, should never be used. There is no indication to use kitchen prepared blenderized diet in a hospitalized patient, especially in an intensive care unit patient. This practice has to be abandoned. And another reason for that is because the micronutrient content is totally unknown. Now, the food scientists may say that a certain amount of trace element or B vitamins are present in the food that you're giving the patient blenderized, but then that has to be made in a bioavailable form to the patient before it is even absorbed, and many times it is not. Acid suppression may cause decreased release of micronutrients from the food. It is only the scientific formulas that can reasonably assure you that micronutrient deficiencies will not occur. The storage form of micronutrients, both vitamins and trace elements, are generally in the liver, with some exceptions which I'm going to talk to you later. And when you give large doses of soluble vitamins and trace elements, you can produce hepatotoxicity, but water-soluble vitamins are quite safe. Micronutrients generally catalyze, regulate fundamental biological processes, and deficiencies affect metabolic processes and enzymatic functions, poor wound healing, organ dysfunction, altered immune status, and deleterious sequelae. But remember that micronutrients work in unison rather than individually. So you need all micronutrients for optimal effects. And the 2002, 09, and 2016 guidelines, all of them very, very clearly state that micronutrients, vitamins and trace elements included, should be components of all parenteral nutrition and enteral nutrition formulations. Of course, there's a confusion about terms. When you give a suboptimal intake, deficiencies occur. When you replete it, then the levels improve, and so that would be called you're complementing the patient's intake. But when you supplement it, then you might actually go beyond the reference range, and the supplementation may mean either the usual requirements or mega doses of vitamins and trace elements for which there is no indication at all. Now, what are the conditions affecting micronutrient requirements? Alcohol abuse is foremost in my mind. Thiamine, folate, B6A, zinc deficiencies occur with alcohol intake. History of poor oral intake and multiple deficiencies, polypharmacies occur in older patients. GI problems like fistulas, diarrhea, malabsorption, chyle leaks. Renal failure is especially a situation where micronutrient deficiencies commonly occur. And obesity, both pre and post bariatric surgery, about which we are going to talk a little bit more. It is very common in obese patients, and even if supplements are given, deficiencies occur. The reasons are not very clear. There is a wide variation in the report, but then deficiency of every vitamin and trace element has been reported in the obese patient. When you look, when you do a Google search or a PubMed search and combine the words obesity, critical care, and micronutrients, you won't find too much of information combining all three of them. But there is no doubt at all, in critical care you have micronutrient deficiencies, and in obesity you have micronutrient deficiencies. In bariatric surgery, for example, it is more common after bypass procedures for reasons I mentioned earlier than restrictive procedures like gastric banding, and all fat-soluble vitamins, B vitamins, iron, zinc, and copper deficiencies have been shown after bariatric surgery. Now the question is, do we have to monitor vitamins and trace element status? They are not routinely measured because tests are not available for micronutrients like especially trace elements. You need trace element free needles and tubes, very difficult to get. It takes several days to get back the results, by which time the usefulness of the results of the test may not be beneficial to the patient. Several forms of vitamins, provitamins, and metabolites are measured. Several isoforms of vitamins are measured, and levels do not indicate deficiencies, and it represents redistribution. For example, iron levels go down, copper levels actually go up during critical illness, and supplementation may not increase the serum levels, but we do lab tests at times only because they are the best available clinical tool available. But when you have organ dysfunction like hepatic or renal insufficiency, long-term parenteral nutrition, especially when more than the usual doses are given, and after bariatric surgery, you have to check micronutrient deficiencies. The clinical diagnosis of micronutrient deficiencies based upon cardiac conditions, anemia, or muscle pains can be detected or suspected as seen in this slide. Skin and mucosal changes occur with a multitude of micronutrient deficiencies. Neurologic manifestations occur with thiamine, copper. I've seen patients with paraplegia because of copper deficiency. And this slide actually lists these rather confusing and overlapping signs and symptoms of micronutrient deficiencies. Drug nutrient interactions must be kept in mind because many of our patients have polypharmacy. When you give antimicrobial agents, vitamin K deficiencies occur. Proton pump inhibitors like pantoprazole that are given, very common to patients, results in hypomagnesemia. Of course, magnesium is really not a micronutrient, but I thought I will mention this. ACE inhibitors and angiotensin receptor blockade medications that are used for hypertension results in zincuria and zinc deficiency. Now, here are a couple of slides of niacin deficiency as shown here, and the references are very clearly seen over here. An old lady with weight loss, poor oral intake with only vegetables, admitted with diarrhea, mental changes, and skin rashes, dermatitis, dementia, and sometimes can even result in death. This is typical niacin deficiency. So now let's go on to a few other specific micronutrients. B1, for example, is a very common deficiency that occurs in critical illness. You need vitamin B1 or thiamine for the conversion of pyruvate to acetyl coenzyme A. And if you do not have enough thiamine, then lactate gets accumulated and unexplained lactic acidosis occurs with thiamine deficiency. It is very common with alcoholics, high carbohydrate intake, a component of refeeding syndrome, iatrogenic refeeding syndrome, and in conditions of malabsorption. But I would say that alcoholism is the highest risk factor. And the manifestations are refractory metabolic acidosis, mental changes, confusion, confabulation, so-called vernix encephalopathy. I never make a diagnosis of delirium in the ICU unless I've given the patient thiamine. Congestive heart failure can occur not only from selenium deficiency but also thiamine deficiency, so-called wet beriberi, and severe abdominal pain, unexplained abdominal pain where all the tests are normal, also occurs with thiamine deficiency. Here is a reference to show how 30% of hospitalized patients may be diagnosed with congestive heart failure, and the reason for that, namely thiamine deficiency, is not suspected. It is common in patients with alcohol abuse, but doesn't mean a patient without a history of alcohol abuse cannot have thiamine deficiency, or parenteral nutrition may be given without enough thiamine. And recently, thiamine deficiency has been listed as a component of refeeding syndrome, usually manifested as unexplained metabolic acidosis or congestive failure, to a point but that in Europe, thiamine at doses of 100 to 200 milligrams a day, remember the requirement is only about 5 milligrams a day, is recommended for all patients in the intensive care unit while enteral feeding progression takes place. If there is no plan for enteral feeding, then the patient is given parenteral thiamine. Now, what about this rash? This is typical scurvy. And surprisingly, the scurvy in an ICU patient in the present time is unusual, but it is true. Here is a patient on a food fad diet, high protein, high fat, and this is the corkscrew shaped hairs or extremities. It's a perifollicular petechiae. Tiny spots of bleeding can occur. But mega doses of vitamin C are never indicated in the ICU. There is no effect on survival, hospital, or ICU length of stay. And here is a nice review in sepsis and COVID, mixed ICU patients, and getting serum levels are of no value and higher doses are still recommended in some guidelines. But as a monotherapy can not be recommended in sepsis or in septic shock or in all critical illness. Now here is an alcoholic patient, excessive alcohol intake, failure to thrive, and cracked scales in extremities and the skin as seen over here. This is called acrodermatitis enteropathica. This is a very common presentation of zinc deficiency. Here are other examples of the rash in skin deficiencies. Remember the term acrodermatitis enteropathica. Zinc content of the human body is the highest for any trace element except for iron. But 95% is intracellular, that is why serum levels may not really help you. It has important roles in immune system, anti-inflammation, antioxidant, component of over 70 metalloenzymes listed on the slide, many of which are quite familiar to you. Important roles in protein, carbohydrate metabolism, and deficiencies occur with excessive GI losses, especially high output fistulas, bile leaks, pancreatic insufficiency, trauma, burns, especially alcoholism, renal insufficiency, and patients who are on renal replacement therapy, high dose steroids, HIV, and malignancies. In renal replacement therapy, this paper shows very clearly that based on effluent losses, there's an increased requirement for zinc. Unfortunately, zinc for parenteral use is not available in India. Zinc for isolated parenteral use, it is available as multiple trace elements. But there are no studies to show that by giving extra zinc, outcomes are actually improved. So remember the term acrodermatitis enteropathica, the characteristic skin rash over face. And other features of zinc deficiency are glucose intolerance, loss of hair, altered taste, dysgeusia or smell, dysosmia, diarrhea, detrimental effects on respiratory function and on hepatic function. Now, what about inflammation and zinc? Serum zinc levels decrease rapidly with acute phase response in the perioperative period, respiratory failure, and in most critical illness. So, zinc levels correlate with increased levels of IL-6 and TNF-alpha. Therefore, when you have a patient who is stressed, there is no point at all in getting zinc levels because the zinc levels can be predicted to go down because of the acute phase response. So when do you measure zinc levels? Only when you have increased GI losses, increased skin losses, long-term parenteral nutrition, pancreatic insufficiency, short gut syndrome, or renal replacement therapy. Otherwise, there's no reason to measure zinc. But there is no evidence in COVID especially to give mega doses of zinc. There is absolutely no convincing evidence to show that pre-morbid levels affect survival or susceptibility to COVID, and there is no evidence to show that benefit of additional supplementation in critical ill patients, including COVID patients, are of absolutely no use. You can imagine how much of money companies made with zinc during the COVID crisis. And the Center for Disease Control, for example, clearly states that they cannot make a recommendation for or against, but they say don't give above the recommended daily allowance for the prevention of COVID. Now, selenium is an important enzyme which is a component of glutathione peroxidase, and it is important for thyroid hormone production. It also inhibits nuclear transcription factor kappa B, which is an inflammation expression role, which has the inflammation expressive role. And the role of selenium in thyroid has recently been publicized even more. So when you do not have thiamine deficiency, you can have hypothyroidism. It occurs in alcoholism when you have resected the duodenum and proximal jejunum, inflammatory bowel disease, chyle leaks, or when selenium is not added to parenteral nutrition. It presents as cardiomyopathy, congestive heart failure, arrhythmias. Originally, it was in China, in children, Keshan's province in China called Keshan's disease, and the peripheral muscles are involved producing muscle weakness and muscle cramps because of selenium deficiency. Here is a condition of a blue sclera. What do you think is because of a blue sclera? It is because of iron deficiency. And one of the causes of iron deficiency in the ICU is unnecessary lab tests, and it is called anemia of chronic investigation. Lot of lab tests in ICU is done for no reason at all. And by limiting lab tests, the quality of care is not compromised. So I would tell you that if you limit lab tests, you can prevent iron deficiency anemia. What about vitamin D? So much of information is available about vitamin D and so much of misinformation. It is true that vitamin D receptors are found in the cardiovascular system. It has got important role in glucose metabolism and also immune dysfunction. But the controversies are the studies on vitamin D in critical care have many times flawed because the levels are obtained after resuscitation with fluids, low vitamin D levels because of hemodilution. Therefore, the patient was never deficient in the first place, and then you give extra vitamin D depending on those levels. And naturally there was no information. So, in non-ICU and ambulatory patients, slow correction over several weeks are perfectly all right. Dr. Berger's papers clearly shows that you can give maybe 2 or 3 times the daily requirement of vitamin D, but mega doses rapid correction is not needed in an intensive care unit. And here is a paper that shows in a double-blind placebo-controlled study of over 1,000 patients, the single dose of vitamin D had absolutely no effect on mortality or no other non-fatal outcomes, and especially in COVID again, there is absolutely no indication that mega doses of vitamin D are needed, only maybe twice the usual daily requirement. Now, vitamin A is very interesting because it has effects on wound healing, as you very well know, and when a patient is on steroids, wound healing is affected. So vitamin A is the only known vitamin, the only known way by which you can partially cut down or attenuate the effect of steroids on wound healing. So anytime you have patients who are coming to us post-operatively, like ulcerative colitis, who's been on steroids, then we give vitamin A. Now, vitamin K is interesting. There is no storage form of vitamin K in the body, and it is available in the body from diet and bacterial synthesis. So if you give antibiotics, there is no vitamin K produced. The patient is nil by mouth, and therefore there is no vitamin K. So prothrombin time may not detect subclinical deficiencies, and the patient may go to surgery with vitamin K deficiency. Therefore, dietitians should strongly recommend prophylactic or preemptive administration of vitamin K to patients who have not eaten for 4 or 5 days. And when you give parenteral vitamins, make sure that the product contains at least 150 micrograms of vitamin K. Now, should antioxidant cocktails be routinely used in critical illness? It has been very clear that antioxidant activity is by enzymes, not directly by micronutrients, and therefore low dose multivitamins and trace elements are justified, but high doses are not needed, and in some studies even show harm to the patient. Here is also yet another paper that just came out just 2 or 3 weeks ago to show in patients with continuous renal replacement therapy, it is okay to give higher doses. But higher doses of thiamine, vitamin C, D, selenium, iron, and zinc may be required only in very, very specific conditions. And single high dose should not be delivered anymore. This paper also talks a little bit about iron deficiency anemia, which is frequent, and I would suggest you read it because it has got some very good information that under guidance you may have to give iron to some of the intensive care unit patients. I was happy to be part of this systemic review with meta-analysis and a trial sequential analysis by Dr. Gudivada, formerly in St. John's Medical College in India and now in Hyderabad, that evidence of antioxidant supplementation in critically ill patient is questionable. And a subsequent paper, of which I was happy to be involved with, no evidence to support antioxidant micronutrient supplementation over and above the daily requirement or what is present in standard enteral or parenteral nutrition. We're coming to the end of my talk, and I want you to look at this very carefully. What about this 30-year-old patient about whom I told you earlier with excessive alcohol intake? Very clearly thiamine deficiency. I'm sure all of you will be convinced. And this patient with a high mid-ileal output is very clearly zinc deficiency, and rashes like this occur not infrequent. Now, the key points of my talk are that safe guidelines have already been published both by Aspen and Society for Critical Care about micronutrients and vitamins. Clinical interpretation is very important, but it's not always needed. Clinical interpretation by lab tests. Parenteral and enteral formulas should contain the recommended amounts of micronutrients, and if you're using the GI tract, make sure it is in the bioavailable form. And micronutrient in sepsis and in critical care are no different from other conditions. Thank you very much.